Well, good morning, everyone. Good to have you along. And, of course, I'm feeling healthier already just having Dr. Seagraves in the room. So he just brings that comforting presence. All right. Welcome once again to Health Talk. I'm Peter Christian. That's John King. Hey, John.
Hey, good morning.
How was your weekend?
Oh, it was great. I got to enjoy the hailstorm live and up front at
Rose
Hours parking lot.
I saw you with your handful of hailstones.
Yeah, it ripped all the petals off the flowers in the market. I hope they recover.
Oh, well.
Yeah, it looks like we're in for some interesting days.
Yes, absolutely. But that's not what we're here to talk about right now. We have Dr. Stan Seagraves, who is an MD and a hospitalist at Providence St. Patrick Hospital. Stan, welcome. It's good to see you.
Thanks a lot.
Of course, we have a history anyway because our kids went to school together and they're now all in the medical profession. Some of them are anyway, right?
Correct. I have a couple of nurse daughters right now who keep me honest.
and in St. Bernard's, I understand.
Correct.
All right. Tell us a little bit about Stan Seagraves and how you got involved in medicine in the first place.
Well, I'm originally from Oregon. I trained in internal medicine back in the old days, in the old pre-hospitalist model, actually. And my wife and family and I moved out here in 1989, practiced at the Western Montana Clinic as an internist until 2008 when I switched over to my current position as a hospitalist. Although, as maybe we'll get a chance to elaborate later, like family physicians and internists, we're all were and continue to be hospitalists in the sense that we had experience practicing in the hospital. So I'm a 25-year guy here.
Now, what is a hospitalist? I can't even write this word without getting a red line under it on any kind of word processor. So I'm not even sure it's a real job. Why don't you tell us what it is?
It's sometimes it's a real job. Some of my partners would tell you that I don't have a real job because I'm down here on the radio while they're actually doing the work.
Everyone says that to us too.
They're healing the sick, and you're
Correct.
on the radio. Yeah.
Those of you who are listening, get after it. It's an awkward term. It's kind of a clunky term. So is internist, really, when you think about it. It doesn't roll off the tongue, but it's a descriptive term for a physician or a non-physician provider, so a PA, a nurse practitioner, who limits their practice to a hospital setting. So you could be a generalist hospitalist. You could be, in my case, an adult hospitalist, pediatric hospitalist. We have psychiatric hospitalists. In some larger hospitals, there are surgical hospitalists. So someone that's defined by where you're hanging out.
So do you have like a bumper sticker on your car that says, "I don't do home visits," or?
I do not have that sticker yet.
But is that basically the difference between a traditional doctor and a hospitalist? Just that you don't go out in the field?
It's that you don't have an office-based practice,
right.
And you spend your day working in the hospital and in your area of specialty.
Is it kind of a modern change to medicine?
It's about a 20-year-old specialty or so, probably the most rapidly growing specialty there's ever been. It's a little bit of a fake specialty in this sense that, like I referred to earlier, it's work I was doing before, but now I've narrowed my physical location and my time to inpatient work.
Now, before we got on the air, you had given me a really good example of what you do and kind of compared it to being a contractor. I was hoping you could give that example to the listeners out there because it gave me the best insight into what your job is really like.
At least for the generalist hospitalist, so whether this is a pediatrician or an adult medicine hospitalist, I think the best analogy is that of the general contractor. You need to know a little bit about a lot, I should say, and you can know a lot about some stuff too, but my point is, or I think the analogy works when you think about the fact that the general contractor needs to keep the project, if a patient can be a project in this metaphor, on track. You're juggling a lot of tests, a lot of medications, a lot of family dynamics, a lot of specialists, and your job is to keep all that going forward.
Now, are you restricted to a certain number of patients? Because I can just imagine if you've got, there's 150 people in a hospital and you're the, general hospitalist, that's a lot of dishes to keep, spinning.
Yes, we try to limit it to a reasonable amount of work just so you can do a good job.
Right.
On the other hand, unlike the office-based practitioner who can set a schedule and turn off the spigot, so to speak, the emergency room stays busy all the time, and patients come in. So we just need to kind of suck it up at times and get the work done. We try to keep a reasonable panel of patients so that we can give everybody the attention they need.
So how many hospitalists are there? You kind of described yourself as a general contractor. So is there someone over you and someone over them? Is it a big pyramid sort of formation here?
I like to think of us as being at the top of the heap, but no, we work we work in a collaborative way with the specialty colleagues. So it's really a team sport. It's not just the physician or the non-physician provider, but there are nurses and therapists and specialty physicians, and we're all in it together. There really isn't a strict pecking order. There's always historical pecking orders of sorts. We have a big group, though. We have 22 adult hospitalists, for example.
Oh, wow.
And a number of other pediatric hospitalists, psychiatric hospitalists, intensive care unit physicians, and so on.
So it sounds to me like when you let's say I'm in the hospital and I'm just sick. I'm a sick guy. Okay, I can't feel it. I can't stand up. Whatever. And you come and you do your examinations and you figure, okay, this guy has a neurological disorder. All right. You know enough about that to say, okay, I'm going to call Dr. Beck or one of these other individuals. So you bring in a specialist to contact the patient with that particular problem.
Correct.
Okay.
So unlike, in fact, we were talking about this earlier, unlike the hospitalist model in Europe, in Australia, New Zealand as well, I think, where you came to the hospital with a neurologic or what was thought to be a neurological problem, you would not be admitted by your primary care provider there either. You would be admitted by the specialty service that's closest to what the emergency provider thinks may be wrong with you. There aren't really generalist hospitalists overseas. In any event, in the U.S., our job is to coordinate your care, figure out what specialty service you might need, and then to engage them in your care.
So in many ways, your specialty is diagnostics.
Correct.
It seems to me. That would be
And treatment, I would say. Diagnostic and treatment, non-surgical diagnosis and therapies.
okay. So so what sort of things do you do in what we would think the traditional doctor would do? A lot of what we've talked about so far has been the ferreting of people to the specialist that has the skills that need to fix that problem. But if there isn't really a special, if it's a general problem, then you're hands-on?
That's it. We're it. So you might need a minor procedure. You might have a half dozen very complex chronic illnesses with dozens, sometimes literally dozens of medications that need to be juggled, and that's our baby to tackle that and to manage that.
I was going to ask you about that because personally, in my family, we've had some elderly folks. My wife's mom and dad both passed away, and both of them had several things that were going on at once, and both of them were at St. Patrick Hospital and had wonderful care, by the way. But there were lots of things going on, and there was a hospitalist there. There were eventually there were palliative folks involved, and so how do you blend all those things together to make sure that everything is seamless? And of course, that's the goal, is to make everything seamless. So,
well, the key is communication. I mean, that's sort of a little bit of a trite answer, but it's more important than ever now that we have care so fractionated. So whether it's me interfacing with their primary care doctor or their bevy of specialists, my job is, hospitals spend a lot of time on the phone. I'm trying to keep everybody on task.
Oh, I'm sorry.
yeah, we're going to take a little break.
Yeah, I think we're getting ready for a break here. But when it comes to your job and the interactions with the other doctors, is there ever like a jurisdiction like you would see between like police forces and the FBI or something like that, where you're like, no, this is a general problem. No, it's a specialty problem.
Well, yeah, other than Jeff Fee maybe coming down and telling me what to do. No, there really isn't any hostility. And in a sense, it's the patient and their coordinating primary care provider, and really we are their primary care provider while they're hospitalized, that dictate the course of the treatment.
Okay, we're going to take a little break, come right back, continue our conversation with Dr. Stan Seagraves. You have a question, give us a call. 721-1290 is our number. This is Health Talk, sponsored by Providence Health and Services, Western Montana. Be right back. And even doctors can dance if they want to in this show. It's okay. 721-1290 is our number, 1-800-568-5309. We won't tell, I promise. Dr. Stan Seagraves joining us this morning, hospitalist at Providence St. Patrick Hospital here on Health Talk. So we do have a caller on the line. Catherine, you're on with Dr. Seagraves. Go ahead.
Good morning. Good morning, Doctor.
Morning.
I wanted to ask you about continuity of care before and most especially after hospitalization. Do you follow patients in the community or into the community, whether or not there's another primary care physician?
That's a really great question, an important one too. It's one of the biggest vulnerabilities of the new hospitalist model is this handoff time, this voltage drop when patients leave the hospital. So electronic health records have made it easier to have this handoff, but we are really, really compulsive about calling the primary care provider, making sure that when you leave the hospital, that your out of hospital provider knows where things were left. Now, if someone does not have a physician on admission to the hospital, we, from the minute they hit the hospital, make efforts to connect them with a local clinic. So we really have an unwritten rule that you don't leave the hospital without an appointment having been made with the appropriate primary provider or specialist, because otherwise, that's bad for you, and you're going to be back in the hospital sooner.
Okay. Thank you.
You bet.
Thanks for the call, Catherine.
Do you find electronic medical records fulfilling all the things you would hope that they would fill? I mean, as far as transferring the voltage, you just mentioned the voltage drop sometimes when there's a lack of communication. Hopefully that's not happening, right? So,
well, one answer would be no, but I think that was because our expectations were probably incorrect. The transition to electronic health records has been really hard for healthcare providers, meaning the change in workflow, the way we spend our days. On the other hand, there's a lot of things that we already take for granted in terms of availability of information, immediacy, that have made it a lot easier. For example, when a patient comes to our hospital from an outlying hospital who shares our electronic health record platform, I know things that before would have been dozens of faxes, hours on the phone, and you still wouldn't know what you want to know. So things are much better, not without a cost in terms of changes in the way people do their job.
Let me ask you, just if I can shift gears just a little bit. You and I were talking before the show started about the medical home concept and the fact that you said in the beginning of your practice you actually made some house calls and it was very fulfilling. You had a chance to meet people in their own environment, that sort of thing. That of course has shifted, and you say it may be shifting back toward that model a little bit later on, right?
Yes, I think that's the direction that we're heading, not only in palliative care, but maybe even, hopefully even in the primary care world ultimately. I think it's not only a better service for the patient, but a satisfying, a practice satisfier for the provider. So whereas the hospitalist might not be making those visits, of course, and in fact your primary care doctor might not be making those visits, there may be a team of physicians and other providers, nurses, mid-level providers who go from home to home to see, for example, but not the only example, the frail elderly at their home, save them a trip to the emergency room, save them a trip to the lab, and so on. So I think it's going to shift back, and the electronic health record actually makes some of that very easy, because now your giant electronic chart is on my laptop at your home.
Sure.
So you're not dealing mostly with the extreme specialty problems. You're not dealing with people that can walk up and go to their doctor, their primary care doctor. So are you mostly focused on chronic issues, things that are constantly keeping people sick?
Yeah, yes, and you could almost argue that the primary care doctor's office is oriented that way as well now. But if you meet a hospitalist, you usually have a wide range of pretty serious chronic illnesses. Unlike 20 years ago, where someone would check into the hospital literally to, quote, rule out cancer, unquote, and for a 7-day sort of leisurely evaluation. Those days are over, and if you're in the hospital, you are so sick that you can't be anywhere else. And so whether it's COPD or diabetes or advanced heart failure, on and on, we're dealing with people usually with an overlap of a bunch of serious illnesses.
Do you make the decision on whether or not someone gets screened or tested on one of the different devices that they have at the hospital? Whether or not they get like an MRI or, is that something that you go through, or do you go through a specialist for those decisions?
No, we make most of those calls ourselves, although if there's a discussion point around what would be the best test, certainly we would avail ourselves of the specialty colleagues, but we tend to run the diagnostic side of things and then turn up, for example, diagnoses or questions that then need specialty input. But we order the tests, whether they're imaging tests or laboratory tests.
So in the news, we hear a lot of a debate over, are hospitals testing too much to prevent from getting, people getting sued or whatever, or are we not testing enough? And I wanted to get your take on that whole debate.
You're talking to the son of a lawyer, and he and I argue about this pretty much every time we talk. there's no question, even though the literature's, I think, up in the air about it, there's no question that defensive medicine it plays into how we order tests and what we do. I see people who've had a dozen abdominal CAT scans over the course of 3 years at 4 hospitals for the same not yet sorted out abdominal complaint. It's kind of ridiculous, and you can't tell me that that's not defensive medicine in play. We tried to be mindful of it. The electronic health record has certainly helped get rid of some redundancies. In other words, I don't have to repeat a test because I can see that you just had it 3 weeks ago at another hospital. Absent that information, though, there's a lot of repetitive testing.
So that's helpful. It's preventing duplicative procedures.
Correct.
That's
Big
good to
advantage.
know. That's very interesting.
Now, we're up against another break, and Dr. Stan Seagraves, kind enough to join us this morning here on Health Talk, sponsored by Providence Health and Services of Western Montana. We have all 3 of our phone lines open. You have a question for this is a good doctor right here. So 721-1290 is our number. We're coming right back. 721-1290 is the number, 1-800-568-5309. This is Health Talk, and it's sponsored by Providence Health and Services, Western Montana. We're privileged to have with us in studio Dr. Stan Seagraves, who's a hospitalist at Providence St. Patrick Hospital. Go ahead, John.
So you were mentioning before we got on the air that this is only about a 20-year endeavor, this Hospitalist. You know, as you sit at this juncture here, and we're moving on to into the future, what would you recommend that this job transition into? Where do you see it going? Where do you hope that it goes?
I think we're going to see more and more hospitalist subtypes. For example, as it gets harder and harder to run an office and be present in the hospital with very complicated patients, I think you're going to see surgical specialists go in this direction. Not that it hasn't already started, but I think you're going to see that more widespread. You could call it a fractionation of care or an increased specialization of care, but I think that's the direction it's going. And as communication gets better, and as people recognize this really is a team sport, not one doctor and one patient, then I think, and again, like I said, as we smooth out the communication gaps, I think it's going to be a better model.
And now, as you mentioned earlier, Australia, Europe, pretty much everywhere else in the world has a different system. Why do you think that is, and do you think this system that we have here is better?
Well, I don't know that it's better, although I'm inclined to think it's better to have a generalist coordinating your care, whether you're on the inpatient side as a hospitalized patient or whether you're in the office. The more specialty-oriented approach has some deficits. There's some efficiencies there, but for example, if you get admitted with a lung disease to a hospital in Melbourne, you are admitted by the lung doctor. But what if you also happen to have diabetes and congestive heart failure and a rare skin disorder? So you wind up with a big pile of specialty opinions there as well, and no central coordination. There is not a generalist coordinating your care. I think it's better to have a center point, although at times, you know, if you come to the hospital, and we were talking earlier, if you need your appendix out, let's just get your appendix out. You don't need the hospitalist. If you're otherwise well, a hospitalist helping coordinate that. Yeah. There are some places, though, where hospitalists literally admit and discharge every patient from the hospital. From a throughput, efficiency, very mechanical standpoint, I don't support that.
I remember several years ago when I put my hand in a snowblower, I didn't need a hospitalist. I needed a hand surgeon. You know?
Correct.
So I walked in and my hand was in a mess, and they said, "Okay, well, I think we know what you need."
Yeah. So what you don't need is a snowblower either.
So
Although I do
basically,
have a shovel now.
there's 2 tracks. You've got your emergency room track and your hospitalist track.
Yes, a patient. Most of the patients that we take care of have come through the emergency room. A few are directly admitted from their primary care provider's office. They begin their evaluation in the emergency room, and then when it's evident they need hospital care, the hospitalist steps in and takes it from there.
Do you think that the modernization of technology will make your job easier or will make it obsolete?
Artificial intelligence. I look forward to the day that artificial intelligence can answer a call at 2 a.m. I'm waiting for that. I don't think we'll ever be replaced. I think the nuances, the judgment, the experience, and the complexity are beyond the reasoning of any supercomputer just yet. But certainly there are a lot of diagnostic software packages out there that help you get to the answer more quickly.
We have a minute left in the program, and if you could just talk to young folks out there who are just going into, they want to get into medicine, why become a hospitalist?
Well, I think it's appealing in a number of ways. One of those is the schedule is not as taxing as the old model, which I did for 17 or 18 years, meaning trying to run your office and be present in the hospital and be available after hours. That is a burnout machine, if ever there was one. So it's appealing from the standpoint of being able to turn off your practice and concentrate on the rest of your life. At the same time, it's really exciting. There's lots of bells and whistles and toys to play with in the hospital.
And we're out of time. Thank you so much for being with us, Dr. Seagraves. It's a pleasure.